So I did my quality improvement project on assessing prenatal risk factors, which prenatal risk factors I am categorizing as pregestational diabetes, risk of preeclampsia, and postpartum hemorrhage risk. Those are 3 risk factors that we tend to screen for during and throughout pregnancy. And so I did a quality improvement project on that. And so what is the project assessing? So the project was made to assess whether or not we were actually screening our patients appropriately, our pregnant patients, for pregestational diabetes and preeclampsia in the first trimester, and whether or not we were screening our patients for risk of postpartum hemorrhage in the 3rd trimester. And why do we need this project? So I included a fun picture from our last graduation at St. Mark's Family Medicine Residency. And we have 12 residents and then 2 attendings who all provide OB care. And we have a large number of people. And so I wanted to, so my phone just went off. I'm sorry. So obstetrical care is a strong component of family medicine. It's just a subpart of what our family medicine doctors do. But within OB care, there does exist a different quality metrics and interventions that are unique to OB. And so one of those components are these prenatal risk factors. And each of these risk factors are important because we have the ability to intervene on them and provide better patient outcomes. And with our clinic having 2 attending and 12 residents providing, we have numerous providers caring for our OB patients. And so we strive to have a systematic approach to ensure that we are providing the best care possible. But in this, we have a note template to help us make sure that we're hitting all the required things during our OB care throughout the pregnancy. And often the prompt for prenatal risk factor assessment was left blank. And it was often cited that going to an external source to figure out exactly how we screen our patients for this, and then coming back to the clinic EMR, which our EMR is a little bit clunky anyways, was a little bit too time consuming for our patient or for our providers. And so they often left it blank. And so I wanted to look at being able to increase the number of OB patients that were screened by the appropriate time frame for each of these risk factors. So for pregestational diabetes and preeclampsia risk, this was by the end of the 1st trimester, 14 weeks and 0 days. And for postpartum hemorrhage risk, this was by term, or 37 weeks and 0 days. And so methods to the madness, I did a pre and post intervention data analysis. So my proposed intervention was to create a prenatal risk factor calculator that was embedded in the note for ease of access for providers on the initial first OB visit, and was able to be added to any of the subsequent return OB visits. So they could add it to the 36 or like in their 3rd trimester template. And then I demonstrated the use of this and discussed the significance of screening at a new conference with providers at the beginning of September of 2020. And then I looked at 6 months prior to and 6 months post. So I did from February 1st to August 31st of 2020. And then I did from December 1st to June 30th of 2020. And looked at patients who participated in either a first OB or return OB visit during that time frame. I left a 3-month gap to allow for setup, and then also to allow for some of there to be less carryover of patients. So there's a little bit more of a gap there. And then patients who showed up after the 1st trimester were excluded from pregestational diabetes and preeclampsia risk factor assessment, and then patients who transfer care prior to 37 weeks were excluded from the calculation of postpartum hemorrhage risk. So this allowed for evaluation of our ability to appropriately screen patients based on their gestational age. And this is just some pictures of how it looks in our EMR. Our EMR is a little bit old, it's not Epic, which is unfortunate. But we have the ability to pull in the BMI. And so for pregestational diabetes, it's BMI and one of the following, and would classify them as needing to be screened for diabetes. For needing to start aspirin for preeclampsia, they need 2 of the moderate risk factors or only 1 of the high risk factors. And then for postpartum hemorrhage, you only need 1 of the moderate or high risk to be classified as thus. And so then our results. So the pre-intervention data suggests that there was significant disparity in assessing risk factors in our OB population. And the rate of screening for pregestational diabetes was 29%, 25% for preeclampsia, and 39% for postpartum hemorrhage. Post-intervention data did show some improvement, with rates of screening for pregestational diabetes at 73%, preeclampsia for 80%, and postpartum hemorrhage risk at 60%. A couple things that could be impacting data is that we had an overall increase in the number of patients. So our N went from 27 to 52. In the pre, it was 27, and the post, it was 52. And then we also did have one of our OB attendings did join us for the post-intervention data. So she was not included in the pre-intervention data. So that could have skewed our results as well. And so overall, what did we find and what are the next steps? So we found that by embedding a risk calculator into the EMR, it allowed for patients or for providers to be able to screen their patients appropriately at higher rates than what they were doing previously. Next steps. So overall, the percentage of successfully screening patients for postpartum hemorrhage risk was still lower than first trimester screenings. Likely this is due to the embedding of the risk score calculator into the first OB visit template. So it's already there for the provider to screen for the first trimester risk factors, but requires the provider to actually add it into subsequent encounters. And so if we had it already included into all return OB visit templates, it might be easier for providers to be screening for postpartum hemorrhage risk as well. And then another next step would also be figuring out whether or not this actually impacted patient care. So we have the fact that we did see an increase in screening, but we don't know that that actually impacted patient care. So if A1Cs were checked, or if aspirin was prescribed, or if postpartum hemorrhage risk, if that was elevated, if the deliveries were actually managed with that in mind and able to see that patient outcome was impacted by the screening. And so that would be my next step, would be to actually find out if patient outcomes improved with the screening.